day, colleagues. My name is Sabiha Essack. I am the chairperson of the Global Respiratory Infection Partnership and the South African Research Chair in Antibiotic Resistance and One Health at the University of KwaZulu-Natal in Durban, South Africa. It is my privilege to share with you the leadership role of the pharmacist in implementing the Global Action Plan on Antimicrobial Resistance in the COVID-19 world. My disclosures: I'm chairperson of the Global Respiratory Infection Partnership and member of the Hygiene Council, both sponsored by unrestricted educational grants from Reckitt and Benckiser, United Kingdom. This is an overview of my presentation. I will briefly discuss antibiotics and antibiotic resistance, how the COVID-19 pandemic has confounded the global public health threat of antibiotic resistance, before discussing the leadership role of the pharmacist in the 5 strategic objectives of the Global Action Plan on AMR as listed on this slide. Antibiotics are amongst the greatest achievements of medical science. Since their introduction into clinical practice in the 1930s and 40s with the sulfur drugs and penicillins, antibiotics have dramatically decreased the morbidity and mortality associated with bacterial infections, as evident from the 2 figures on this slide. The first figure shows the crude death rate for infectious diseases in the United States from 1990 to 1996 in the context of public health improvements such as vaccination and the introduction of antibiotics, while the second figure shows the death rate from tuberculosis and other respiratory tract infections before and after the introduction of antibiotics in the US and other countries from different regions of the world. In both instances, we see a drop in mortality because of infectious diseases. We would see exponential increases in the crude death rates, and particularly the death rates from respiratory tract infections, if we had to extend these graphs to 2020. Both increases would be attributable to COVID-19. Antibiotic resistance occurs when bacteria no longer respond to antibiotics that previously killed the bacteria and cured infection. This infographic shows how antibiotic resistance happens. Our bodies carry many bacteria, some of which are resistant. Antibiotics kill bacteria causing the illness, as well as the good bacteria protecting the body from the infection. The drug-resistant bacteria are now allowed to grow and take over, and some bacteria give their drug resistance to other bacteria, causing more problems. Antibiotic resistance is a function of time and use. The greater the quantities of antibiotics used and the longer the period of time for which they are used, the greater the selection pressure for the development of resistance. This is a normal evolutionary process and occurs when antibiotics are used correctly or incorrectly. These infographics show the chronology of the development of antibiotic resistance after introduction into clinical practice based on first published reports. In some instances, resistance was found even before introduction into clinical practice. Resistance exists to every single antibiotic in clinical use. The COVID-19 pandemic has confounded antimicrobial resistance. COVID-19 is a viral respiratory tract infection with clinical manifestations ranging from a mild influenza-like illness to severe pneumonia. Non-severe cases are managed by self-isolation, good hygiene practices, and symptomatic treatment, while at-risk populations are closely monitored for escalation to secondary bacterial infections. Despite the lack of evidence to support their use, antiretrovirals, antimalarials, and antibiotics, singly and in combination, are currently being used in the management of COVID-19, potentially escalating antimicrobial resistance, as evident from these opinion pieces and commentaries. 2 reviews have highlighted inappropriate antibiotic use in hospitalized COVID-19 patients. A rapid living review and meta-analysis of bacterial co-infection in COVID-19 reported that 71% of patients were prescribed antibiotics, despite a mere 3.5% co-infection at presentation, increasing to just 15.5% secondary infections after presentation. Another rapid review on antimicrobial prescribing in COVID-19 patients reported that broad-spectrum empirical antimicrobials were frequently and indiscriminately prescribed in the absence of respiratory, bacterial, or fungal co-infection. On aggregate, 72% of patients received antimicrobial therapy, while 8% had bacterial or fungal co-infection during hospitalization. Every predicted scenario on the impact of antimicrobial resistance will be potentially worsened by COVID-19. We are likely to see greater than 10 million deaths as a result of AMR by 2050, as predicted by the O'Neill reports. Vastly more than 28 million people will be poverty-stricken. There will be more than a 7.5% decline in global livestock production, more than 3.8% decline in global export, and far more than a cost of $1 trillion in additional healthcare costs. Despite several World Health Assembly resolutions on antimicrobial resistance since 1998 and the 2001 Global Strategy for the Containment of Antimicrobial Resistance, political will visibly emerged predominantly in the high-income countries only after 2011, when the World Health Campaign focused on antimicrobial resistance. It was entitled Combat Drug Resistance, No Action Today, No Cure Tomorrow. This was the year in which the World Health Organization launched the 6-point antimicrobial resistance policy package. The policy package was followed by the Global Action Plan on Antimicrobial Resistance in 2015. The Global Action Plan was endorsed by the United Nations Political Declaration on Antimicrobial Resistance, where all member states agreed to develop national action plans based on the 5 strategic objectives of the Global Action Plan. The first of these strategic objectives is to improve the awareness and understanding of antimicrobial resistance by risk communication and education. The second objective speaks to strengthening knowledge through surveillance and research and advocates national AMR surveillance, improving laboratory capacities, and undertaking research and development. The third objective speaks to reducing the incidence of infection through effective hygiene and infection prevention and control in healthcare, in community settings, as well as in animal health by way of biosecurity and good animal husbandry. The fourth objective speaks to optimizing the use of antimicrobial medicines in humans and animals and advocates access to quality antimicrobial medicines, regulation, and antimicrobial stewardship, as well as appropriate use in the veterinary sector and agriculture. The final strategic objective ensures sustainable investment through research and development by measuring the burden of antimicrobial resistance, assessing investment needs, and establishing procedures for participation. The literature highlights the role of the pharmacist in antimicrobial or antibiotic stewardship, but does not adequately recognize the leadership role of the pharmacist in implementing the Global Action Plan on Antimicrobial Resistance. So let's put that to rights. The first question we ask is, why pharmacists? To answer this, I want to draw on the pentagonal framework of the Global Respiratory Infection Partnership. This framework speaks to the role of policy, prescribers, pharmacists, and patients on the prevention of antimicrobial resistance. Policy endorsed by local governments and clinical communities of practice that advance antibiotic stewardship and conservation. It speaks to patient empowerment and education about appropriate antibiotic use and alternative symptomatic treatment options. It includes pharmacy guidance on their stewardship role as educators, providing patients with advice and support on infection management and when to consult a doctor. Prescriber guidance is also included on antibiotic stewardship and effective dialogue with patients, and all of these together are meant to prevent resistance by the rational use of antibiotics. Now, pharmacists are key to this pentagonal framework because pharmacists validate or confirm prescribing practice and thus have tacit oversight of prescribers. Pharmacists are strategically placed to educate patients and effect behavior change in terms of patient demand for antibiotics. Pharmacists are critical to implementation of policy as well as the generation of evidence to inform policy-related interventions. And finally, pharmacists then prevent antibiotic resistance by impacting on policy, prescribing practice, and patient behavior. The pharmacist's leadership role in awareness and education. The pharmacist is either the first or the last point of contact with the health system, and thus ideally placed to create awareness and educate both prescribers and the public on antimicrobial use by way of an app which speaks to A for advocacy, P for policy, and P for practice. The containment of antimicrobial resistance requires advocacy from credible AMR champions. Who better than the pharmacists as custodians of medicines committed to their appropriate use? Policy can be considered in two ways. Firstly, the national AMR policy or strategy, or the national drug or medicines policy. Alternatively, policies in the form of treatment guidelines with associated essential medicines lists are also another form of policy that can advance antimicrobial stewardship. Again, well within the purview of pharmacists. Practice moves into the socio-behavioral domain of prescribing and dispensing practice and patient perception and behavior. Here, education and awareness is critical in that prescribers and dispensers should have solid education in antimicrobial stewardship, while patients should be made aware of the importance of taking antibiotics only when needed. In relation to COVID-19, the vast majority, more than 80% of patients, develop uncomplicated illness and can be managed on an outpatient basis. Although there is very little literature on the management of non-hospitalized COVID-19 cases, inappropriate antibiotic use in self-limiting upper respiratory tract infections of viral etiology in community settings is very well documented. Indeed, antibiotic use at community level may be higher in countries where antibiotics can be procured over the counter without a prescription and from informal drug sellers. So the bottom line regarding antibiotics in COVID-19 is that antibiotics do not work against viruses, they only work against bacteria. COVID-19 is caused by a virus, and therefore antibiotics should not be used as a means of prevention or treatment. However, if patients are hospitalized with COVID-19, they may receive antibiotics since bacterial co-infection is possible. The pharmacist's leadership role in surveillance and research. While the pharmacist may not be intimately involved in this strategic objective in terms of the surveillance of antimicrobial resistance, pharmacists are best placed to undertake the surveillance of antimicrobial use and correlate this use data with resistance data. There is WHO guidance which speaks to antimicrobial consumption data, denominator data, as well as contextual information related to antimicrobial consumption. That being said, the surveillance of antimicrobial resistance and antimicrobial use, as well as antimicrobial stewardship, seems to have been deprioritized as healthcare systems have focused on the COVID-19 response. The pharmacist's leadership role in hygiene and infection prevention and control. Pharmacists can prevent or reduce the incidence and transmission of infections in communities by facilitating vaccination campaigns and promoting hygiene, sanitation, and hand washing. If there is a reduction in infection, there is an automatic reduction in antibiotic use, which would then reduce the selection pressure for resistance. World Health Organization guidelines includes hand washing, avoiding personal contact, and using masks in the COVID-19 pandemic, and never has personal and targeted home hygiene and the use of personal protective equipment been more important. In the hospital environment, pharmacists may participate in the Infection Prevention and Control Committee, ensure the availability of cleaning agents and personal protective equipment for patients and personnel safety, establish pharmacy quality control programs to prevent contamination of pharmaceutical products, especially sterile products, encourage the use of single-dose packages of sterile products, and recommend proper labeling, dating, and storage of sterile products. World Health Organization guidelines and PPE are as follows: to start up with performing hand hygiene, putting on the gown, putting on the mask, putting on eyewear, and finally putting on gloves. PPE shortages during the COVID-19 pandemic have been reported from both high and low-income countries. Here I want to highlight the role of the pharmacist at national policy level as well as local practice level. At the national policy level, pharmacists should advocate rational medicines use, defined as patients receiving the appropriate medicines in doses that meet their own individual requirements for an adequate period of time and at the lowest cost to both them and the community. Pharmacists should further participate in drug regulatory bodies to ensure the safety, efficacy, and quality of medicines. They should implement the AWARE categorization in the essential medicines list, optimize supply chain management, and identify substandard and falsified drugs. I want to speak a little bit more about the AWARE categorization. This is a categorization introduced in the latest essential medicines list developed by the World Health Organization, and it consists of 3 groups. The access group of antibiotics consists of antibiotics with activity against a wide range of common susceptible pathogens with lower resistance potential than antibiotics in other groups. These are the first-line essential antibiotics that should be widely available, affordable, and quality assured. The watch group of antibiotics includes classes that have higher resistance potential and/or antibiotics that are relatively high risk of selection of bacterial resistance. They include most of the highest priority antibiotics listed in the critically important antimicrobials for human medicine. And finally, the reserve group of antibiotics consists of antibiotics that should be reserved for treatment of confirmed or suspected infections due to multi-drug resistant organisms. Reserve group antibiotics should be treated as last resort options. Now, COVID-19 has interrupted supply chains by the closure of borders and travel restrictions and made room for substandard and falsified drugs. The most alarming statistic is that more than a third of substandard and falsified medicines reported to the WHO are access and watch antibiotics. To continue with the pharmacist leadership role in optimal antimicrobial use, we will now speak about antimicrobial stewardship, which promotes the safe, rational, correct, and effective use of antimicrobial agents to promote positive patient outcomes, that is rapid recovery from illness or infection, to prevent and contains antimicrobial resistance, and reduces healthcare costs. Antimicrobial stewardship is generally understood as the 4 R's, the right dose at the right time of the right antibiotic for the right duration. At the practice level, we have the 4 R's, and I have expanded these to the 8 D's of antimicrobial stewardship. The first D is diagnosis, where one must ensure a non-viral etiology. This is particularly important in COVID-19, where we must ensure that the infection is bacterial or fungal and not viral. Rapid diagnostic tests play a very important role here. The second D relates to the drug, where one must choose the antimicrobial that is indicated with the correct spectrum of activity, opting for narrow spectrum in the first instance. The third D is dosage form. Choose the dosage form that best suits the patient and the infection. For example, pediatric versus adult, or suspensions and tablets versus injections. The fourth D is the dose. Here we must ensure that the dose will result in concentrations above the minimum inhibitory concentration at the site of infection, taking into account pharmacokinetics and pharmacodynamics. The dosing interval is equally important as the fifth D. In keeping with pharmacokinetics and dynamics, dosing intervals should ensure that the antimicrobial concentration remains above the MIC to prevent the emergence of resistance from sub-inhibitory concentrations of the antimicrobial at the site of infection. The sixth D speaks to duration, and this brings in the hit them hard and fast, short duration, high dose therapy versus the longer duration of conventional therapy. The latter is thought to have a greater selection pressure for the evolution of resistance. Disposal is often neglected, but we must ensure the correct disposal such that antibiotics do not contaminate water and sanitation systems. And the final D speaks to dialogue, which is communication between the prescriber and the pharmacist, as well as the pharmacist and the patient, which is critical to ensure the correct and appropriate use of the antimicrobial. The World Health Organization guidance on the clinical management of COVID-19 states as follows. We recommend for patients with suspected or mild COVID-19 against the use of antibiotic therapy or prophylaxis. Similarly, suspected or confirmed moderate COVID-19 patients, the patient should not be prescribed antibiotics unless there is a clinical suspicion of bacterial infection. For suspected or confirmed severe COVID-19, the use of empiric antimicrobials to treat all likely pathogens based on clinical judgment, patient-host factors, and local epidemiology should be used, and this should be done as soon as possible, ideally with blood cultures obtained first. Antimicrobial therapy should be assessed daily for de-escalation. Still continuing with the leadership role in optimal antimicrobial use, key elements of this antimicrobial stewardship include accurate quality data from countrywide surveillance of antimicrobial use and the level and spread of antimicrobial resistance, infection prevention and control measures, education and awareness, understanding of social and behavioral factors that influence availability, accessibility, prescription, and the use of antimicrobial agents, and strengthening information technology and infrastructure. You will see that I have put in the strategic objectives of the Global Action Plan in brackets under each one of these key elements. A successful stewardship program relies on the majority of the strategic objectives of the Global Action Plan on antimicrobial resistance. The pharmacist's leadership role in research and development. Pharmacists are key to vaccine development, drug discovery, novel drug formulations such as nanoparticles for targeted delivery or sustained release formulations, identification of new antibiotic targets using molecular biology, as well as rapid diagnostic tests. Never has research and development of vaccines, rapid diagnostics, and antivirals been more important. So just the message to say that currently that there are no specific medicines recommended to prevent or treat COVID-19. However, those infected with the virus should receive appropriate care to relieve and treat symptoms, that is symptomatic treatment, and those with severe illness should receive optimized supportive care. Some specific treatments are under investigation and will be tested through clinical trials. The World Health Organization is helping to accelerate research and development efforts with a range of partners. In conclusion, pharmacists have immense capacity to contribute to the stewardship and conservation of dwindling antimicrobial resources exacerbated by the COVID-19 pandemic. Pharmacists should actively mobilize and entrench their leadership roles in the prevention and containment of antimicrobial resistance, both individually and collectively, through pharmacy associations, organizations, and regulatory bodies in both policy and practice. Thank you for the privilege of your time.